Hello, everyone. I just wanted to welcome you all to the webinar today. We'll be talking about public policy and healthcare in the USA with a focus on revitalizing primary care. And this stems from the Lancet Commission on Public Policy and Health in the Trump Era. I am Dan Erkes. I'm a senior editor for the Lancet, and I'm going to be just introducing our panel today, or at least one of the people. Just some housekeeping. Attendees are welcome to submit questions throughout the presentation. Use the Ask a Question box on the dashboard. On the webinar dashboard, you'll see a box with related resources. A link to related Lancet content is featured and will take you to lancet.com. You can also adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences. A link to the on-demand version of the webinar will be emailed to all once the event is concluded. And once the webinar is ended, please complete our 30-second survey so we can continue to improve our webinar offerings. So I'd like to introduce Dr. Robert Rock, who is a family physician and second-year fellow within the National Clinician Scholars Program at Yale University. He is also a member of the Social Mission Alliance, where he leads the Health Justice Fellowship and chairs the Advocacy Advisory Council. His interests include interdisciplinary curriculum design and merging community-oriented primary care, policy-driven community-based participatory research to advance health equity. And with that, I will hand it over to Dr. Rock.
Thank you so much. Greetings, everyone, from whatever time zone you're logging in from. It's my honor to chair this important discussion, both as a family medicine physician and as a care recipient. It's the title for our talk tonight, or this afternoon, or morning, wherever you are, is Revitalizing Primary Care, a Health Justice Imperative. So primary care in the United States is in precarious shape. The fragile state of primary care contributes to the U.S. having the worst health outcomes of all high-income nations, while spending 50% more on health per capita. Despite abundant research demonstrating that a well-supported foundation of primary care is associated with better health outcomes and health equity, as well as lower healthcare costs, the U.S. has neglected this critical sector. Only about 5% of U.S. health expenditures are spent on primary care, half or less than the proportion spent in Canada and Europe, and insufficient to provide the services needed and make primary care an attractive career. This profit-oriented, market-based U.S. health system does not promote primary care as a common good and serves as a structural barrier to reaping primary care's benefits. This seminar will highlight the crisis of primary care and the bold policy actions needed to revitalize primary care. Dr. Kevin Grumbach, a U.S. family physician, will start off our conversation with reviewing the state of primary care in the United States and discuss his proposal for primary care for all, a tax-financed, single-payer system of universal coverage specifically for primary care, funded at twice the level of current spending on primary care in the United States. Dr. Bex Fisher will go next. She's a UK general practitioner and policy advisor, and she'll offer lessons from the British National Health Service, both its strengths and its stresses under UK austerity policies, that can inform efforts to strengthen primary care in the United States under a universal program. Finally, Ms. Nina Graham, a U.S. primary care patient activist, will share her views on the critical importance of high-quality primary care and how patients and the public should partner with clinicians and other primary care workers in a social movement to drive policy changes to revitalize primary care. And before we get to our speakers, I just want to take the time to really introduce them and let you know how incredible a group we have and a rich conversation we're surely going to have over the next hour. So Dr. Kevin Grumbach serves as the chair of the UCSF Department of Family Medicine and Family and Community Medicine from 2003 to 2022, and as vice president for population health for the UCSF Health System from 2015 to 2018. He is a founding director of the UCSF Center for Excellence in Primary Care and director of the Community Engagement Program for the UCSF Clinical and Translational Science Institute. His research and scholarship on the primary care workforce, innovations in primary care, racial and ethnic diversity in the health professions, and community health improvement and health equity have widely influenced policy and practice. With Tom Bodenheimer, he co-authored the best-selling textbook on health policy, Understanding Health Policy, A Clinical Approach, now in its 8th edition, and the book, Improving Primary Care, Strategies and Tools for a Better Practice, published by McGraw-Hill. He received a Generalist Physician Faculty Scholar Award from the Robert Wood Johnson Foundation, the Health Resource and Service Administration Award for Health Workforce Research on Diversity, the Richard E. Cohn Award for Excellence in Leadership in Cultivating Community Partnerships in Higher Education, and the UCSF Chancellor's Public Service Award, and is a member of the National Academy of Medicine. Dr. Bex Fisher is a Commonwealth Fund Harkness Fellow in Health Policy and Practice, based at the University of California, San Francisco. More normally, she is an NHS GP and Senior Policy Fellow at the Health Foundation, where she leads the organization's work on primary care policy. Her interests center on equitable provision of primary care services and models of care and payment for general practice. Bex was previously National Medical Director's Clinical Fellow to Sir Bruce Coe, and is co-founder of Next Generation GP. Finally, we have Nina Graham. She's a primary care patient activist. She has a passion to see primary care at the top of the healthcare pyramid. She is a longstanding member of the San Francisco General Hospital Family Health Center Patient Advisory Council and a member of the steering committee for the national organization Patients for Primary Care. She's a 2-time cancer survivor and recipient of a kidney transplant. Ms. Graham was born and raised and continues to reside in the Bayview neighborhood of San Francisco. She's a diehard San Francisco Giants and 49ers fan and loves to travel. She's active in the Rafiki Coalition on Health and Wellness in San Francisco. And so with that, I'll pass it to Kevin.
Thanks so much, Robert. I always realize hearing that introduction, and there's that comment about widely influenced policy in the United States, and maybe I think that's just an aspirational biography, unless you want to blame me for influencing the mess of a system we have in the United States. So let me orient you to what I'm going to cover today in my talk. So I'm going to start with just a definition of primary care so we can level set a bit about what we're talking about. I will then follow up on some of the comments Dr. Rock made about primary care being an essential common good, and then the precarious state of primary care, particularly in the United States. But I think, as you'll hear from Dr. Fisher, we're not completely alone in that. And then we'll quickly touch on decades of, well-intentioned efforts to reform and strengthen primary care in the United States, but really have not gotten us anywhere close to where we need to be to have a strong, vibrant primary care sector in the United States. And then I'm going to propose a vision for much more transformative change, which what I'm calling Primary Care for All is the program I would like to see us implement in the United States. And then we'll talk about the how to get there. And I know we already have a comment from one of our attendees today saying, okay, a bunch of policy people talking, how is this going to change things? So I actually want to speak to that about how we can mobilize in a very active way to create the change we want to see in the world. So the primary care, I'm going to start with primary care as a functional definition based on the seminal work of Barbara Starfield, a pediatrician and public health physician, the late Dr. Starfield, who really, I think, made it very clear what we're talking about. So primary care, it's not a specialty per se, it's a function that be carried out by a variety of health workers. So she talked about the 4 C's, which are first, contact care, meaning primary care is where you start your journey in the healthcare system, the portal of entry, whether it's for an acute problem or a chronic condition or a psychosocial need, preventive care. It's comprehensive. Those of us working in primary care should be able to take care of the vast majority of the healthcare needs of the patients we care for. It's about relationships with continuity, where you have longitudinal kind of connection over time and really understand people as whole people and the trajectory of their lives. And the final C is coordination. It's the place that integrates care. So people for sure need specialty care. They may need home care, physical therapy, other services, but it all gets brought home by having a primary care home that can synthesize and put it together for the whole person and make it work in partnership with the patient. So that's primary care. So it can be a family doctor like Dr. Rock or myself. It could be a nurse practitioner in primary care. It could be other folks working in primary care, general internists, pediatricians, and so forth. But we're doing primary care if we're providing care that meets these four essential functional features. The evidence. There is abundant evidence that strong primary care makes a difference in the health of the public and people's lives. This is one of the best recent studies. It was a really rigorous study done by Sanjay Basu and colleagues, and it looked at counties within the United States and looked at changes in primary care physician supply per capita over 10 years and their association with changes in life expectancy. And actually, a majority of counties lost supply of primary care physicians per capita. But in those that had an increase, you could see a very strong association with about 100 days increase in life expectancy over this 10-year span. Associated with 10 more primary care physicians per 100,000 people living in a county. And what all these different point estimates are just different methods they used, using regression models, using instrumental variables, more econometric type models. But what you can see, they all hover around 100 days from the different methods of life expectancy increase. I mean, that's real stuff, that primary care helps people to live longer and better lives. Here's another study now looking at variation across states in the United States, where you can see a point here for each state. And this is measuring Medicare beneficiaries in the United States and looking at a summary quality of care score for each state for people on Medicare. And you can see, again, a very positive relationship with better quality associated with a higher supply of primary care physicians per capita. When you then say, well, what about cost? You see a slope that goes in the opposite direction, which is what we'd like to see. You actually see less spending per Medicare beneficiary in those states with higher primary care physicians per capita. So that's like the ultimate goal, right, of health policy, is to get better quality, better outcomes at low cost, the so-called triple aim. And we're seeing that very close association with primary care. Primary care, as the title of today's webinar suggests, also has a very strong connection with equity. And you can start with just looking, if we talk about first contact care, what is first contact care across communities, particularly for communities at the lower income, have more people from marginalized social groups, under-resourced communities? You will see the foundation of access to care in those communities tends to be primary care, whether that's a rural, isolated community geographically, where pretty much that's the only game in town. Maybe it's a physician assistant or a primary care doctor and their team in a rural area, whether you go into lower income urban areas and it'll be a community health center that is predominantly going to be primary care focused. There's also some really good research, again, on stronger primary care is associated with much less inequities in outcomes across communities. You see, for example, white rates, black populations, white populations in the United States have about the same rates of visiting primary care physicians, where there's much lower relative visits to specialists. I mean, an inequity in that respect. So all of these kind of growing research findings led this very high profile National Academies Committee in the United States to issue a report 2 years ago, which cited this evidence and said, for this reason, primary care is a common good, which means it matters to everybody in society to have well-functioning primary care. And many of you may say, well, doesn't all healthcare count as a common good? And ideally, I think we should see it that way. But particularly in this very market-driven context of United States healthcare, I think this committee said it's really important to hold primary care as this essential common good that we all need and benefit from. And the tragedy is, despite primary care having this evidence as a common good, we've had a catastrophic failure in the United States to support primary care. And again, Dr. Rock mentioned some of these types of red flags. Close to half of visits in office-based practice in the United States are in primary care, and yet we only have about a third of our workforce in primary care. Again, if we moved to the National Health Service. It's closer to 40 or 50% of physicians in the United Kingdom who are in primary care. As Dr. Rock mentioned, most high-income nations spend upwards of 10% or higher of their overall health expenditures on primary care. We're in the 5 to 6 cents on the dollar range. Closely tied with that is our primary care physicians earn considerably less than physicians and specialists careers in the United States. The lack of support, the overwhelming need, the troubles with access to care are contributing to burnout among people working in primary care. And for the public, it means poor access. It means terrible health outcomes, with the average life expectancy in the United States now 4 years shorter than the life expectancy on average in the other group of 7 high-income nations. Terrible inequities and crushing costs and waste because of this very inefficient investment of the resources we have that don't go where they're needed most in primary care. I want to just touch on this whole issue of why spending on primary care is related to our deficiencies in the workforce. So as I said, we have real trouble these days recruiting medical school graduates to take on careers in family medicine and general internal medicine. And a lot of people say, oh, well, we just need to change the culture in medical schools. And I'll own some of that, being an academic physician. But I think we're missing the real drivers, which is just students looking out and saying, I could earn a lot more as a radiologist, as a cardiologist. And what these trends show is the blue line is showing the relative income of family physicians in the United States relative to specialists over time. And then you're seeing in the red line, the proportion of graduating medical schools in the United States who say at graduation that they plan to become a primary care physician. And you can see a very close tracking of these two curves with, as the income disparity increases, fewer people want to become family doctors. And as the income disparity closes, more go into that. And so I always say, you don't get into medical school because you don't know how to do arithmetic. I think students see this. The average medical student is coming out $200,000 in debt in the United States, crushing debt, again, very different from our high-income nation comparatives, where medical education is also funded as a public good. So this is all the crisis of primary care. Now, we've had decades of policies to try to, incrementally change this. It started with managed care in the 1990s. So I started as a family physician in 1988. And so then I saw, oh, managed care is here, and that's going to put primary care front and center. And that came and went. Then here's a whole bunch of subsequent things. We had the patient-centered medical home initiatives and paying more differently if you can be recognized as a medical home. Family medicine organizations lost the big initiative, Family Medicine for America's Health. We had the Affordable Care Act that was enacted in 2010. I was very involved in some of the work on that bill to try to include measures to support primary care, a 10% increase here in Medicare payments for primary care, things like that. It spawned the ACOs movements, alternative primary care payment models like comprehensive primary care, CPC done in Medicare, but all kind of small demonstration projects, move to population health. But I'd have to kind of cite that famous line of Ronald Reagan, who I don't usually quote, but saying, are you better off now than you were 4 years ago? And when I look at all these, I don't think the average primary care clinician in the United States would say, we're better off 35 years later than we were at the beginning of all these types of initiatives. So we have to think much bigger and much more boldly about what's required. And we know what's needed. It's not a mystery. It's not like we haven't figured out what the solution is. It's money, as I say. You need to at least double the spending to get more in line where other nations with more rational approaches are. You need to invest in teams. So you need to take that increased funding and not just invest in more family doctors and other clinicians, but in behavioral health workers, in health coaches, in community health workers, in pharmacists. You need to build out primary care teams to really have a much more robust group that can deal with the incredible needs people have for highly effective primary care. A shout out to the Warriors. I can't resist as a San Francisco including that. And then finally, you take that money and it also allows you to invest in time for physicians and clinicians to talk with patients, to not be so distracted by all these things that keep us from just being there, building on our relationships and complex shared decision making with patients. So, we know where we need to get to. So how are we going to get there? So before I say how, I said, well, why haven't we got there? Why have we not made greater progress? And so I kind of looked at some people from the social sciences to help me with insights into that. The first is Paul Starr, who wrote a very prominent book in the United States, The Social Transformation of American Medicine, which came out in 1982, 40 years ago. And the first sentence of that book, I think, is incredibly powerful. It says, the dream of reason did not take power into account. And I've realized I spent a lot of my life trying to produce the evidence, cite the evidence, disseminate the evidence, all the kind of thing I've shared with you today about why primary care is so critical for a highly functioning healthcare system. And I've increasingly realized that it's not just about reason. It's about political and economic power and all the interests in the United States who benefit from the status quo, who benefit from a market-driven, very specialized biomedical, hospital, acute care-centric system, because there's huge profits to be made there in a way that you really can't monetize primary care in this market-driven system. The second person I consulted was Rosemary Stevens, a brilliant medical historian in the United States, who wrote 20 years ago in a piece for a Future of Family Medicine initiative, this sentence, which I'll allow you to read. But that really hit home that this is part of the problem. We don't have a central public entity that really can plan healthcare and really assert primary care and its central role. And again, when you look at our comparative nations, that's something they all have. They have a system where government, in overseeing healthcare delivery, even in mixed kind of public-private payment models, can design the system and affirm primary care centrally. And so she commented that, maybe you'd have to think about a single-payer system as being a necessary factor to put primary care where it needs to be. So, in this increasingly market-driven healthcare system, I've also realized, there's been all this for-profit, investor-owned initiatives, now private equity, and they were all going into specialty care, hospital care, biotech, and nobody was investing in primary care. Now, all of a sudden, lo and behold, private equity said, gee, let's start investing in primary care. A prominent article here in the New England Journal of Medicine, it mentioned that there's been a 1,000-fold increase in the past 10 years of private equity investing in primary care. And it gave me the feeling I had in high school. I don't know if any of you had this, where you weren't part of the in crowd and the cool group in high school, and nobody invited you to parties and really wanted to talk to you. And then all of a sudden, the cool people decided, let's, invite Kevin to some things. And you always have a little suspicion that they had some ulterior motive in doing that. It wasn't because they really liked you and what you were doing, but there was something they were trying to gain from that you weren't totally aware of. That's what I'm feeling like with all this private equity investment. It's not because investors have said, we understand primary care is so important to a well-functioning, equitable health system. It's because there's money to be made, particularly in Medicare Advantage. And you have to have primary care physicians to be able to play in Medicare Advantage and game that system. So I'm not seeing this as a great rescue of primary care. So here's my proposal, and I'll close and turn it over to Dr. Fisher quickly. So I actually think we need primary care for all in the United States, which I'm defining as carving primary care services out of the rest of the mess of our pluralistic public-private financing system, create a single-payer, tax-funded program specifically to pay for primary care. Everybody in the U.S. would be eligible. They could pick the primary care clinician that they wanted to be their primary care clinician. They would have no out-of-pocket payments for primary care service, not just preventive care, but all primary care service, and would use what in the United States we call direct primary care. It's essentially a per member per month capitated payment to the primary care practice, funded by, though, a government sponsor, not by individual subscriber. And it would be adjusted largely for social factors, Dr. Bex will get into this a little bit. How do you do kind of equity-focused funding of primary care? And we would double the budget for primary care from the 5 to 6% to 12 to 14%. So that's what it would look like. It would actually not look too differently from National Health Service general practice funding in the National Health Service. So many of you, particularly in this audience, may be saying, well, come on, Kevin, isn't this a cop-out? Why not just go for Medicare for all? Why not have a single payer for the entire nation rather than doing this just for primary care for all services? And I tell you my feeling, I'd be all for a comprehensive single payer program. I am extremely distraught that there is an impending collapse of primary care, and we need to do something very soon or this system is just going to crumble. So I feel an urgency to do something starting with primary care. There is momentum in several states to move some bills forward that are moving in this direction. So I think there is some traction we can get, particularly at state government. And then I do believe we could get it done at a primary care level. This might then be a stepping stone for a more broader single payer program. So let me close on my last slide on how are we going to get there? Well, I think we got to get out of our kind of traditional physician guild mentality of lobbying and really build a broad-based social movement demanding fundamental democratization of healthcare, beginning with primary care. And that's why I'm so delighted to have my friend and colleague, Nina Graham, with us from Patients for Primary Care, because I think we need allies. We need clinician allies across our disciplines, but we particularly need to engage the public and patients. We've started to try to do this with Patients for Primary Care organizations, but I think we need to build a real broad strategy to mobilize politically and demand much more radical changes in U.S. healthcare, beginning with primary care. So with that, let me turn it over to Dr. Bex Fisher.
Kevin, thank you so much, and thank you for inviting me to speak. I'm going to offer, as you've already suggested, a perspective from the National Health Service in the UK. I actually qualified that already by saying it's mostly data from England I'm going to use. The NHS is devolved across the 4 nations. And what I want to show you is that universal single-payer healthcare is possible. It's possible to do primary care really well within it. But I also want to share some of the challenges that we have and show you that even within a system that in theory you would think is more equitable, and it probably is, you can still have some pretty significant inequities, one that I think the US can learn from as it hopefully journeys towards a better model of primary care and primary care payment. So this will be familiar to some of you. It's the opening line of the NHS Constitution. It's an agreement between the government and the people of the UK. I'm not going to read it out for you, but as you read it, let me cover the highlights that some of you will already be aware of. But in the UK, we have a tax-funded, single-payer universal health system. Its fundamental tenets are that it is free at the point of delivery and use, and that use of the service and prioritization is based on clinical need, not your ability to pay. And this is a slightly cheeky slide, so forgive me, but there is a serious point behind this, which is a graph that shows health spending of a share of GDP. I've predated it before COVID because governments did funny things with COVID money and put it in different directions. But my point here is that you can deliver a universal health system, achieve better outcomes with less cost. So in the UK, we spend just under 10% or around 10% of our GDP on healthcare. That's around 188 billion a year, compared to almost 19% of GDP in the US. So it is categorically not true that Kevin's type of plan would be more expensive. But this is a really important slide. So I meant you'll be aware that the NHS is pretty tightly controlled by government. And what governments do with the NHS matters very much to what patients experience from it. And so this graph shows you average growth in NHS spend in different governments over time. And what you'll see is that the long-term average is a 3.6% increase in growth year on year. Sounds pretty decent. Some governments have put an awful lot more money into the NHS. So under the Blair and Brown Labour governments of the late 90s and the noughties, the NHS got an average 6.7% additional funding year on year. Under the governments of the last 13 years, we've had austerity politics, and that has dropped significantly. So we've had between 1% and 2% average funding increase for the NHS over the last 13 years. So That's below the historical average, but massively below its kind of immediate predecessor. And that's really important context for some of the challenges that I'm about to talk about. And I'd also encourage you to think about, well, okay, when you have a health system that is so tightly run by government, it's also, the prevailing winds of government have a real effect on what can be delivered and what is realistic. But I want to talk to you for a moment about how primary care is run within the NHS, or more specifically, general practice. And I'm using those terms very deliberately because I'm now not talking about primary care as I would understand it. The NHS funds dentistry, community pharmacy, optometry slightly differently. So I'm now talking about, essentially the speciality of family medicine. And it's almost as if we planned it. Kevin mentioned Barbara Starfield and her framework, and that's what I'm going to use to explain this. So we know that health systems that are based on primary care are more effective, more efficient, more equitable. And Starfield provides us a framework for understanding, well, what does a health system based on primary care look like? And so I just want to explain how we do things in NHS general practice using the 4 Cs. Firstly, we have a tight gatekeeper model. If you think you have an appendicitis, you can go straight to the emergency room, same as if you've probably broken your leg on a soccer pitch. But with almost everything else, you're going to go and see your GP first. And the GP acts as a tight gatekeeper for referrals to see a specialist. Once you've seen a specialist, the specialist will eventually discharge you back to the care of your GP, who manages all of your ongoing care. We also have a pretty good model, theoretically, for continuity of care. Citizens register with a GP surgery, usually the one geographically closest to their home. There are about 7,500 GP surgeries in England. And they're allocated a named GP. They can choose to see any doctor in that practice. Most practices have between 5 and 10 GPs working in them, as well as a bunch of other staff. But you'll have a named GP. And certainly your care will be at that health centre. And we also have a pretty good model for comprehensive care. We have a national contract held between GPs and NHS England, which specifies which services have to be delivered by general practice. And so there's an intentional mechanism for keeping it broad, and also for specifying pretty standard things like what opening hours you should have. We also, theoretically, have a good model for care coordination. GPs in the UK were really early adopters of electronic health records. We have really great informational continuity within practice. We have national contracts that, again, theoretically specify requirements for quick communication between hospitals and GPs. So far, you're probably thinking this is kind of utopia. I've described this great vision, and I think I have. Genuinely, I believe that there is very high fidelity between Starfield's model of high-performing primary care and the way that we deliver general practice in the NHS. But there's a slight difference between theory and reality at the moment, and that's what I'm about to address. So this graph shows you one of our challenges, and the y-axis is quite big here, so it probably makes the challenge seem smaller than it is. And it is that we have really soaring demand for appointments in general practice. This line is a bit wiggly because it reflects data over the time of the pandemic. But between January this year and January of last year, there was a 15% increase in the number of appointments being done in general practice. So that's pretty massive. General practice is delivering over 30 million appointments a month in general practice in England. Well, you might say, fine. As long as you've got enough staff, that's okay. And you'd probably be right. But hey presto, we don't have enough GPs. So we share a challenge that you have in the US with high levels of burnout, low job satisfaction, and attrition from the primary care physician workforce. And so the number of permanent, fully qualified GPs has fallen pretty significantly in the last 7 years, despite a government manifesto commitment to increase the number of GPs first by 5,000 and 6,000. We're actually just over 2,000 full-time GPs below the baseline when those manifesto commitments were made. So we've got increasing demand, pretty staggering rate, and the number of GPs is decreasing. We are getting more early career doctors into GP training, but a challenge that we have is that the participation rates in the labour market, so their conversion to full-time equivalent doctors, isn't the same. The response to working extremely long days under high pressure is very understandably to do fewer of those very long days. And this leaves us with headlines like this. So for us, primary care is a very political issue now. It is the front door to the NHS. depending on the numbers that you use, it probably delivers between 85 and 90% of patient contact in the NHS. So when there's a problem in primary care with access, it becomes a political problem because people go to their member of parliament dissatisfied and politicians get interested. So these are all headlines from the last 6 months or so. But what we've seen is a massive drop off a cliff in public satisfaction with access to general practice. It always used to be the most popular NHS service. In 2022, there was a 30 percentage point drop in public satisfaction with general practice. So that's a pretty massive cliff to fall off. But are those problems shared equally across England? Well, what I'm going to talk about now is something called the inverse care law, which will be familiar to many of you. It was first described in a 1971 Lancet article by this guy. He's one of my heroes. He's a Welsh GP called Julian Tudor Hart. And he said that the availability of good medical care tends to vary inversely with the need for it in the population served. He also incidentally said that is more true where there are greater market forces. I'd really commend that paper to those of you who haven't yet read it. And a couple of years ago, some colleagues at the Health Foundation and I set out to try and work out, well, how applicable is this inverse care law to NHS general practice today? And the first thing we need to think about is, well, is need equally distributed across England? And so I'm just going to talk you through these graphs. This first one shows the percentage of patients with 2 or more long-term illnesses by IMD score. IMD score is the index of multiple deprivation. It's a kind of area-based social vulnerability index that we use in the UK. And what you're looking at on the left side of your screen, IMD score 1 is the richest areas. And as you move across to IMD score 10, that's the poorest 10% of areas. And so unsurprisingly, what you see is as you move from richer areas to poorer areas, people have more health conditions in poorer areas and they get those health conditions at earlier ages. So the poorest 10% are twice as likely to be multimorbid by the time they reach 70. How does that translate into appointments in general practice? Well, again, this looks like a horrible wiggly graph, and I'm sorry that's because it reflects time through COVID, but I just want you to focus on 2 colors here. The red line at the top is the poorest areas. The blue line at the bottom is the richest areas. And what we're looking at is the number of consultations per person per year. So how many times does each person see their GP? And we see a pretty big difference. If you live in the poorest 10% of areas, you're going to see your GP on average 6 times a year, and it's going to be 4.5 times a year if you live in the richest areas. I know you don't see a GP half a time a year, but it's an average. And this is a very crude example, but if you imagine you're a practice and you've got 10,000 patients, then if you're in the richest areas, that's going to translate into 45,000 appointments a year. In the poorest areas, that's going to be more like 60,000 appointments a year. That's pretty much 30% more in the poorest areas. So again, you might look at that and you might say, well, okay, there's more demand for healthcare in the poorest areas, but as long as there's more doctors and there's more money, that's fine. And you'd probably be right. But you probably guessed I'm about to show you that that isn't the case in the NHS now. So this graph, and I promise I won't show you too many more graphs, but this one shows you trends in payments to GP practices and how that changes depending on how deprived an area is. And we've just said that you would expect practices to have more money in the more deprived areas because there is more health demand. But actually what we see is the absolute inverse of that relationship. So practices in the most affluent areas are in fact getting more money from the government. Practice in the most deprived areas are getting the least, about 7% less funding per weighted registered patient. How does that translate into staffing? Well, this graph shows you how many GPs there are per 100,000 patients and how that varies by deprivation. And again, we have the red line representing the poorest areas at the bottom, the green line representing the most affluent areas at the top. So we have effectively more GPs working in our richer areas and fewer GPs working in our poorer areas. In fact, a GP working in the most deprived areas is on average responsible for almost 10% more patients. So I think it's safe to say that the inverse care law is alive and well in general practice in the NHS now. And compared to more affluent areas, poorer areas have greater population health need, higher consultation rates, but they get less funding, have fewer GPs and shorter GP consultations. I don't have time to go into the nitty-gritty of exactly why that is now, but a lot of it has to do with how we distribute funding. So we use a formula to divide up money between practices. It has weighting for a lot of things, but it really underweights for the health need generated by socioeconomic deprivation. And so it skews money towards practices in affluent areas and away from practices in poorer areas. And I just want to conclude by talking about some of the policy challenges that we have at the moment, and then some reflections that I have, having spent almost a year now living in the US. I guess this is my personal horse, but we have inequity in the provision of GP services. So just having a universal health system is not enough to guarantee equitable access to care. We have a big issue with the business model of general practice. We, like you, have a lot of small practices, but people, especially GPs of my generation, don't really want to be business holders in the same way that perhaps previous generations of GPs did. So we need to work out how we're going to direct money into general practice in the future. We have massive issues with GP recruitment, retention, and distribution. That comes back to some of the job satisfaction and burnout challenges that I spoke about earlier. And we're still really working out, as are you guys, how we better do team-based care. How do we integrate a broader skills mix of professionals in general practice? And then we always argue about the slice of the NHS pie. We get about 9% in general practice at the moment, which 9% for 80 to 90% of contact seems to me like, not a great ratio. I realize it's better than 5%. So here are my lessons and cautionary tales. You can have universal single payer health systems with really strong primary care. And I really believe that the UK has the structure and funding right. When I talk to you about Starfield's framework and how well applies to the NHS, theoretically, we have great alignment. I'd push back very strongly against arguments that rear their heads in the UK around moving to social insurance-based models. Our model is not the problem, but our funding is. And I would invite you to reflect on that slide where I showed you how much different governments have spent on the NHS. And within that, we underfund primary care. Tackling health inequalities means resourcing your universal health system in proportion with population need. And that means paying attention to risk allocation formula. They don't sound like the most sexy thing, but to me, they kind of are really vital to equity within health systems, because how we distribute resource really matters. And then the final thing I want to say is that, of course, primary care physician job quality is a major issue and threat in both of our countries. Thank you so much for having me speak today. I'm going to pass on to Yanina.
Thank you, Doctor. And thanks for this opportunity to speak. I want to first give you a background on myself and the medical journey I've been on that has brought me where I am today. When I was 28, my kidneys failed, and since then I've had 2 kidney transplants. I'm 5 years in on my second transplant. I was on dialysis for over 18 years, which most of that time I did not have a primary care physician. When I was lucky, and I have been lucky enough in the last 10 years to have one, but when I was going through so many medical things in the beginning of my journey, I had no coordinator. I was just going, I would say, from specialty to specialty. Yeah, that's how that worked. So fast forward, I started seeing a physician here at the Family Health Center at San Francisco General. And that has been for me a wonderful experience. It's changed everything in my medical journey so much. So I can speak to how important it is to have a great primary care physician and to have a great relationship with that person, where that person knows me, I say fully, the whole me, not just a small part, but he's actually coordinating all of my care now. And as a patient here at the Family Health Center, I was approached and given the opportunity to join the Patient Advisory Council, which gave me an opportunity, was presented to me as an opportunity to affect change in the clinic as a patient. And I didn't really know how that was going to work because, you know, patients aren't really important in the clinic. But not so. I found out through the PAC, the Patient Advisory Council. I found out that, or I was able to see the example of when you care about what the patient needs and what's important to the patient, you can make things better. You have better health outcomes. You have better results. Before I let me go back. Before I was involved in the PAC, I was able to see also the patient's voice activated in my dialysis unit, which was going to be farmed out to a private corporation. But before that happened, the patients were organized by some of the nurses at the clinic, and we went downtown and we spoke to some of the policymakers, the supervisors at City Hall, and they wanted to hear from us. They invited the patients and the administration from the hospital. And once the administration from the hospital heard from the patients and heard that how this move and the sale of our little clinic would affect the patients directly, then they decided that they wouldn't sell the unit and that they would keep it here at the hospital and move it into a new space that would work better. And it was all based on what the patient said. The CEO at the time turned to me and said, you know, I apologize that we didn't take patients into consideration. They were thinking about the bottom line, and if they could get rid of the unit and not have to worry about providing a space in the new hospital for it, then that would work for them. But like I said, the patient's voice rang out, and they listened. So that was my first experience when with seeing that the patient's voice could actually make a change, and that has inspired me to want to do more for my clinic and for primary care. Like the doctors both said, primary care in the U.S. is a mess. But it's not a mess everywhere. There are good examples. The Family Health Center where I am is a good example of a system that works. And one of the reasons that it works is because they listen to patients. For the past few years, they've actually involved patients in interviewing residents for the residency program. And what an honor it is to be able to help in the selection of the residents who are going to come in and be the new doctors in our clinic. That's one way. And that's also put me in touch with a wonderful group of patients who are organized under the name Patients for Primary Care.org, and you can check that out. And it's a group of patients who've come together to talk about why primary care is important to them as a patient, and and to let people know what is important besides all the other stuff, like I said, that the other doctors talked about, the finance, you know, getting the making the changes, but for personal, what it means to patients personally, and how a good primary care system or a bad primary care system affects patients. Um, and it's really important. It's really important work for patients. So I would say that part of the solution, one of the tools to get the policies changed, I believe, is patients and the patient's voice, and what patients can bring to the table, and what and if people are listening, are open to hear patients, their patients, activists, and advisors, they're hard to come by. They're not all out there because I believe that they don't all know, they don't all have their voices yet. That's why I'm willing to speak. It took a long time to get a voice. I would say my primary care provider now helps me with that voice, for myself and to affect change for others. I would like to see patients and the community involved in every aspect of their care and their medical surroundings, their clinic, whatever it is, to be able to affect the change along with the clinicians and the staff, and wherever they are. And my hope is just that patients are utilized more and brought into these conversations and taken seriously, and given the opportunity to let what's inside of them, come out and be told. And I also believe that when that happens, when you can show patients that they are being heard, they become more engaged with their care, and that alone would bring out better health outcomes for patients. The being involved with patients for primary care isn't was really is it's an honor, and it's an important, I would say, position for me at this time, because I realize from speaking to others in my family and in my community, the disconnect between the community and primary care. When you get to see your primary care, once every 3 or 4 months, you can't really make or get a good relationship going. But with the changes that I hope to see coming down the line, then I hope those changes can be made, and I hope that patients are used as a tool. And I like to thank you for giving me this opportunity to speak, and I really appreciate being here with you all, and you listening to me. Thank you.
Thank you so much, Nina. And thank you, Bex, and thank you, Kevin, for really educating the group, giving us a context, showing us what the future could be, what it should be, and really, closing with the personal impact of what we're talking about and how it affects the lives and the health trajectories of the people that we're doing this for in the first place. So, want to use our last remaining 4 minutes to answer as many questions as possible. The first question I actually placed before we even started speaking, and it's from Sanjeev Bhavnani. And the question is, how on earth do we expect academic discussions like this to translate into actual policy decisions? And given the expertise of the panel, I offer it to any of you, to whoever feels led to answer that question.
I mean, if I could, Robert, I don't want to pretend it's simple. I mean, I think what I've tried to do is say it's not enough to just talk policy evidence. People who are committed to making primary care work need a political strategy, and we need to recognize the formidable interests that are benefiting from the status quo and are resistant to change. And they're very powerful. And I think business as usual, which has tended to be, my organizations in family medicine, which I'm a member of, I believe in, but we're sort of tinkering at the margins. We're not up in our game to really look at the structural factors that are perpetuating the status quo. So that's it. And so I think it's both being much more calling out the forces of extractive capitalism, of the threats to democracy or the lack of democracy in the United States, that we need to take those head on. And then we can't do it alone. And it can't just be, a lobbyist for a professional society is going to make the change. I think that's why working with folks like Nina and others, and how we start to build this much broader community and learn from the movements of Black Lives Matter, about the Sunrise movement around environmental thing. I think we need to channel that spirit in really building a social and political movement.
Thank you so much for that. Nina, I know your personal accounts in terms of fighting for the ownership of the dialysis center kind of speak to this, but is there anything else that you'd like to add?
Just that I've had the opportunity many times to see the patients, the voice affect change, and I just really hope that it can be used in a broader way, that the patient's voice could be used in a broader way.
Thank you. The next question is from Asma Jaffrey. The first part is, do you think things will get worse in primary care before improving, thinking in the United States specifically? And they specifically asked if you can comment on NPs and PAs filling the gap for physicians in primary care.
Yeah, if I can take that one again a little bit. That's why I use the expression primary care clinician intentionally, because it's not just physicians. I mean, physician assistants, nurse practitioners play a critical role as clinicians in primary care. We still have a crisis even accounting for that. They are not sufficient to meet the workforce needs for primary care clinicians in this country. And the same forces that are affecting fewer physicians going to primary care are affecting the other health professionals. The proportion of physician assistants going into primary care has plummeted. Many more now going into specialty care. So I think highly valued, but some of the same threats are affecting that part of the workforce. Will it get better before it gets worse? I guess that is kind of the United States way of doing things. I think maybe I'll turn that back to Bex. I mean, I think you gave it's very sensitive to the political regime in power, and I guess it's almost a question there. What do you think about will it get worse in the UK, given who's in power in government before it gets better?
I mean, it's difficult for us. This is a very, it's something that is very much in the political sphere. And I think, look, politicians of all parties can act. And if you're in my position, you're begging all of them to act. Like, I am trying to work with government, and I'm also trying to work with opposition to influence manifestos. And I think, we're at the point, if, like me, your interest is improving primary care, getting more equitable primary care, then you want to work with whoever has the power to do that. And just to kind of, so I hope we don't get worse before we get better in the UK, because I think that what worse looks like is real people having worsening health conditions in real pain, and it's just not acceptable. But part of the route to that is by having people help us make this a political issue as well. So another route to that, how is this not an academic conversation? How is it a policy conversation? It's about folk who listen to things like this going away and thinking, well, not just, okay, maybe that was interesting, but what am I going to do about that? If I've heard something that is interesting, or if I've heard something that is problematic, how am I going to be involved in taking that forward or being a solution to it? So I don't think this is ever just about the people who talk about stuff. It's also about what we can all do about stuff, and that will be different depending on where we are within the system.
All right, thank you so much.
Right, because I just close it. Yeah, because let's end on an action. So it's not just there. Look, there are very concrete actions. One can create your own patients for primary care network. Work with, if for those of you who are healthcare, workers, how do you reach out and start building this? And whether it's your local patient advisory council at a practice, how do you start thinking of that? Connect with Patients for Primary Care. It's P4PC, P4PC.org. Check it out. Get people to sign up there. Work within, find, are there coalitions can you build? Can you start building across nursing, physicians, other health workers, unions? Start really building this, start centering this notion of primary care for all and what a program would look like. I'm putting a resolution into my state Academy of Family Medicine to support a primary care for all state bill. So I still think it's worth working within our organizations, American College of Physicians, American Academy of Pediatricians, American Nursing Association. I think we need to reach out to consumer groups and things like that. But I think there are very concrete things people can put into practice to take a concept like primary care for all and say, let's start getting state legislation moving forward on this. Let's start building the coalitions to really take action. Don't just attend the webinar. Act.
Yes, and with that call to action, unfortunately, we're going to close. 60 minutes is never enough to really wrap our minds around all of this. But thank you all so much for coming and for participating. We've recorded this and it'll be accessible in the future. Please mark your calendars and keep a lookout for advertisements for our next event. The topic is, should investors own healthcare? And it'll happen September 26th at 2 p.m. Eastern time. I think it's a very appropriate follow-up for the conversations that we're having in terms of the capture of primary care in the United States. So thank you so much to everyone, and thank you so much to our speakers for your time and your expertise, and we'll see you all next time.